Good evening, everyone. Today I will be talking on congenital CNS anomalies. More than 2,000 anomalies have been described in the central nervous system. It accounts for around 1% of total live births, and it is seen in around 75% of fetal deaths. Around one-third of total anomalies in the body are due to central nervous system anomalies. Of these, 10% are due to chromosomal abnormalities, and 20% are due to inheritance, and 10% are due to intrauterine environment infections, and 60% there is no definite identifiable cause. Just to list the methods of examination, radiological examination, it includes MRI, CT, antenatal ultrasonography, and occasional conventional imaging. Standard classification of CNS malformations, it can be divided into, initially there is formation of cell, that is cytogenesis, which forms the tissue, that is histogenesis, and tissue goes on to form the organ, that is organogenesis. Based on this, we have disorders of organogenesis, that is again due to neural tube closure, diverticulation of cleavage abnormalities, sulcation or cellular migration abnormalities, abnormalities of the size and destructive lesions, and again disorders of histogenesis that accounts for neurocutaneous syndromes or phacomatosis, and disorders of cytogenesis that leads to congenital neoplasm. Before we go ahead with this, we need to understand the embryology of the formation of the brains to identify the CNS anomalies. Initially, the brain is formed with the formation of brain vesicles, which is formed at 6 to 8 weeks. Primarily, there are 3 vesicles, which are known as prosencephalon, mesencephalon, and rhombencephalon. These go on to form 5 secondary vesicles, that is telencephalon, diencephalon from the prosencephalon. Telencephalon forms cerebral hemispheres and with the cavity of the lateral ventricle, and diencephalon forms the thalami with the cavity of third ventricle. Mesencephalon continues to form as mesencephalon in secondary vesicle, which forms the midbrain. Rhombencephalon divides into metencephalon and malencephalon. Metencephalon leads to pons cerebellum, malencephalon leads to medulla oblongata. Coming to the dorsal induction anomalies, it includes Chiari malformation, encephaloceles, lipomas, spinal dysraphism, and anencephaly. The ventral induction anomalies include holoprosencephaly, septo-optic dysplasia, agenesis of the septum pellucidum, cerebral hypoplasia and aplasia, and Dandy-Walker malformation. From 2 to 4 months after the formation of brain vesicle, there is neuronal proliferation and histogenesis, and from 4 to 7 months there is neuronal migration. The anomalies of proliferation include microcephaly and macrocephaly, whereas anomalies of histogenesis include phacomatosis, that is neurofibromatosis type 1, type 2, tuberous sclerosis, Sturge-Weber syndrome, and hydranencephaly. The anomalies of migration, this is due to abnormal passage of the neurons along the guiding glial fibers. These anomalies include focal break, which leads to schizencephaly, or generalized transient abnormality of migration leads to agaria or pachygyria complex, and heterotopias and hydranencephaly. From 6 months to years after birth, there is organization and myelination of the brain. The abnormalities of organization and myelination can be lead to what is known as dysmyelinating disorders or leukodystrophies, and these can be associated with trisomy 21. Okay, now let's start with the disorders of neural tube closure. It includes Chiari malformations, cephaloceles, that is meningoencephalocele, meningoceles or atretic cephaloceles or glioceles, and corpus callosal anomalies, which can be agenesis or dysgenesis, or corpus callosal lipoma. To begin with Chiari malformations, anachoric type 1 malformation, there is it is cerebellar ectopia. There is a caudal descent of the cerebellar tonsils below the level of foramen magnum. When it extends more than 5 mm in case of adults or more than 6 mm in case of children, it is known as abnormal. And there is peg-like pointed tonsils which displays into the upper cervical canal. There can be associated anomalies in the form of hydrocephalus or syringomyelia, but usually there are no associated brain anomalies as such. This is the Chiari 1 malformation. The skeleton anomalies usually associated with this are seen in around 25% cases, which include basilar invagination or Klippel-Feil syndrome, platybasia, and atlanto-occipital assimilation. Here is an example of Chiari type 1 malformation, where you can see that there is caudal descent of cerebellar tonsils below the level of foramen magnum, and there is associated syringohydromyelia that can be seen on the right hand side. This is another example of Chiari 1 malformation with the caudal descent of the cerebellar tonsils always better seen on the sagittal images. On axial images, it can be sometimes difficult to identify this descent, but as you see the sequential skirts, one can identify that there is an inferior descent of the caudal descent of the cerebellar tonsils. This is another example of Chiari malformation with a large fillings in the cord. Coming to the Chiari II malformation. Chiari II is a complex anomaly. The basic etiology is there is fetal neural folds fail to neurulate completely, and there is a persistent dorsal opening and abnormal CSF drainage into the amniotic cavity. Thereby, there is decompression of the primitive ventricle and adverse effect on the endochondral bone formation, which leads to small posterior fossa. The various components of Chiari II malformation are in the skull. You can see lacunar skull, that is leukoencephalon, and small shallow posterior fossa with a gaping foramen magnum. There is hypoplasia of the falx with fenestration of the falx. There is tentorial hypoplasia with wide or broad incisura, and petrous and clavus are posteriorly scalloped, and there can be associated myelomeningocele with dysraphism. In midbrain and cerebellum, again, there is downward displacement of the brainstem and cerebellum. There is associated brainstem abnormalities that are not usually seen in Chiari I malformation. That is, there is medullary kinking, and there is peaking of the tectum, and cerebellum wraps around the brainstem. Again, ventricles and cisterns, lateral ventricles can be dilated. This can be it can be asymmetric dilatation, and the dilatation of the occipital horns leading to colpocephaly. There is also third ventricle is hourglass shaped, and fourth ventricle is elongated, narrow ending below the level of foramen magnum. It can be associated with callosal and septum pellucidum abnormalities. Intrahemispheric fissure can be serrated and in this Chiari II malformation. Again, coming to the associated abnormalities in the spine and cord, it is associated with myelomeningocele. Associated syringohydromelia again can be seen in Chiari II malformation. There can be diastematomyelia. This is again antenatal study showing that there is a Chiari II malformation with the dilatation of the ventricles and hydrocephalus. Herein you can see that there is peaking of the tectum that is seen here, and there is medullary kinking below, and caudal extension of the cerebellar tonsils. And there is associated hypogenesis of the corpus callosum also with the Chiari II malformation. This is again antenatal diagnosis, antenatal ultrasound showing that there is a myelomeningocele associated with the sacral defect here. Coming to the Chiari III malformation, here again the pathology is there is hindbrain herniation into a low occipital or high cervical encephalocele, in addition to the features of Chiari II malformation. This cephalocele can contain portions of the cerebellum or occipital lobes, and herniated tissue can be occasionally non-functioning due to necrosis, gliosis, fibrosis, and presence of heterotopias. Here you can see that there is a low occipital upper cervical encephalocele associated with Chiari II malformation. This is a Chiari III type of malformation. Coming to the Chiari IV malformation, it's a very rare entity. It's also with the absence of severe hypoplastic cerebellum, and there is a small brainstem and a large posterior fossa, unlike other Chiari malformations. But in this large posterior fossa, this can be differentiated from Dandy-Walker malformation, that there is no obstructive hydrocephalus or other CNS anomalies. Coming to the cephaloceles, the pathology, the skull defect with herniation of the intracranial content. It can contain only the brain parenchyma or the meninges, brain parenchyma with meninges, or the CSF filled cavity, based on which it can be called as meningocele, meningoencephalocele, or encephalocystocele. And it can be congenital or acquired. It is seen around 1 to 3 per 10,000 live births. Based on the location, anatomical location, the occipital is the commonest. It is seen between the foramen magnum and lambda. The contents are variable. There can be cerebellum and midbrain seen within the herniated cephalocele. It is also with the neural tube defects, Dandy-Walker malformation, and diastematomyelia. Here you can see that there is a occipital cephalocele with herniation of some amount of brain parenchyma and CSF fluid. And this again, based on the location, this is another type. This is frontoethmoidal cephalocele, which can be seen here. And atretic cephalocele is a skin-covered subcutaneous lesion that consists of meningeal and ectopic foci, glial, and other CNS tissue. It is associated with cerebro-oculomuscular syndrome, that is Walker-Warburg syndrome. Here you can see that there is a skin-covered atretic parietal cephalocele. This is a non-parietal cephalocele where there is a herniated brain parenchyma with meninges. Coming to the anencephaly, it is seen in around 1 in 1,000 live births, 1 in 1,000 births, and it is fatal. And in this, you see that there is total absence of cranial vault and cerebral hemispheres and diencephalic structures, which are replaced by neurovascular structures, and the facial structures and orbits are present, and it is usually fatal. Coming to the ventral induction anomalies, include holoprosencephaly, septo-optic dysplasia, agenesis of the septum pellucidum, corpus callosal abnormalities, cerebral hypoplasia, and Dandy-Walker malformation. Holoprosencephaly is it is basically the complete or partial failure of lateral cleavage into distinct cerebral hemispheres, and there is also failure of cleavage of the ventricles and failure of transverse cleavage into the diencephalon and telencephalon. It is directly related to the mesenchymal tissue of precordial mesoderm, which is responsible for cleavage of telencephalon and development of the facial midline structure. So there is associated usually facial anomalies, especially in case of moderate and severe form. As Dimay says, the face predicts the brain. Usually the facial anomalies also with this brain abnormality. Based on the severity, this can be alobar, semilobar, or lobar holoprosencephaly. Firstly, alobar holoprosencephaly. It's a complete lack of hemispheric and ventricular cleavage, and on imaging there is completely unsegmented rim of brain that surrounds a largely central CSF cavity monoventricle with fused thalami and basal ganglia. There is absolutely no interhemispheric fissure, Fox, or midline corpus callosum structures. So the differential diagnosis includes posterior midline cyst, which is seen here, can be confused with the dorsal third ventricular cyst seen in corpus callosal agencies. Here, these are the examples wherein you can see that there is an undifferentiated brain parenchyma all around with a central monoventricle. This is another example of alobar holoprosencephaly, where there is a brain parenchyma, undifferentiated brain parenchyma with a central monoventricle. This is the antenatal diagnosis again, showing you the monoventricle with fused thalami. Associated anomalies, usually craniofacial anomalies, are like sebocephaly, like a monkey-like head with reflective nose and severe hypothyroidism, or you can have extracranial anomalies like polydactyly, renal dysplasia, and oncolocele. Usually it is associated with trisomy 13. Next type is semilobar holoprosencephaly. Again, it's the intermediate type of holoprosencephaly. There is partially developed occipital and partial cleavage of the cerebral hemispheres, and there is head-shaped monoventricle. Fox is incompletely formed and rudimentary, and there is partial or complete fusion of the basal ganglia. Here you can see that there is relatively some cleavage into the right and left with a head-shaped monoventricle. Associated anomalies, these are absent or very mild facial anomalies, can be seen as a hypothyroidism or median and lateral cleft lip. Coming to the lobar holoprosencephaly, it's nearly complete brain cleavage except few areas where it is still fused, like the basal portion of the frontal lobes. Excuse me. But however, the interhemispheric fissure and Fox is almost completely formed. There is separation of basal ganglia, but the septum pellucidum is usually absent with squared up or box-like composition of the frontal horns. Associated anomalies, there can be hypoplastic optic vesicles or olfactory bulb and mild hypothyroidism. But severe facial anomalies are very rare, unlike the alobar holoprosencephaly. Just to differentiate this, you can see that it's a case of lobar holoprosencephaly. Just to list the findings to differentiate alobar, semilobar, and lobar holoprosencephaly. The ventricles usually is a single monoventricle, whereas some rudimentary occipital horn with head-shaped ventricle is in semilobar. And septum pellucidum is absent in all three types, but Fox cerebri is absent in alobar and is quite well formed in lobar. And even the same is the case with interhemispheric fissure, which is present and with some anterior fusion in case of lobar holoprosencephaly, whereas it is totally absent in case of alobar. But basal ganglia and thalami are totally fused in case of alobar holoprosencephaly, whereas they are separated in lobar holoprosencephaly. Coming to the next entity, that is septo-optic dysplasia. This is considered a very mild form of lobar holoprosencephaly. The basic components, two components of septo-optic dysplasia include absence or disgenesis of the septum pellucidum, and secondly the optic nerve hypoplasia. Based on the observed anomaly, it is divided into two subsets, that is with schizencephaly or without schizencephaly. When it is not observed with schizencephaly, there is diffuse white matter hypoplasia with ventriculomegaly. Here is a case of septo-optic dysplasia, wherein you can see that there is no septum pellucidum and the arrow points to the hypoplasia of the optic nerve. Next, coming to the Hydranencephaly, here the olfactive bulbs and tracts are absent. On imaging, MRI can show that olfactive sulci is seen, but there is absence of olfactive bulb and tract. It occurs as a part of complex cerebrosomatic syndrome, which is also with Kalman syndrome, and is also with Holoprosencephaly. And you can see that there is formation of the olfactive sulcus, but there is no olfactory bulb and tract. Coming to the corpus callosum agenesis, it is usually it can be complete or partial or varying spectrum based on the corpus callosum dysgenesis. Usually corpus callosum forms from the anterior to posterior aspect, and except for the portion of rostrum which forms in the end. So whenever you see an anterior part with a missing posterior part, it is usually developmental related to corpus callosum dysgenesis. But if you see a posterior part present with absent anterior part, it is unlikely to be developmental, more likely to a secondary insult which has caused the destruction of the anterior part of corpus callosum. Again, in this corpus callosal agenesis, the entire corpus callosum may be absent. This is also with high riding third ventricle, which opens superiorly into an intrahemispheric fissure with or without a dorsal cyst. There is radial spoke-like orientation of the gyri, and usually there are parallel non-converging lateral ventricles with, and along its supromedial aspect, there may be white matter tracts indenting on these lateral ventricles, which are known as probes fundus, and is associated with the mild dilatation of the lateral ventricles, which is known as colpocephaly. This is a case of corpus callosal dysgenesis. You can see that there's totally absent corpus callosum. Here again, you can see that there is absent corpus callosum with the radial orientation of the gyri and interdistation of the gyri. This is associated with the associated anomalies with corpus callosal dysgenesis include Chiari II malformation, or it can be associated with migration disorders such as heterotopias, lysencephaly, schizencephaly, or other anomalies such as Cephalocele, Walker malformation, all Holoprosencephaly. Or it can be also with Chiari syndrome, that is the agents of corpus callosum, also with ocular abnormalities and infantile spasms. Other CNS anomaly that can be seen with corpus callosum is corpus callosum lipoma. This is due to persistence of the meninx primitiva, which is a mesenchymal neurorectus derivative. It is the lipomas are seen in corpus callosal area in around 30%, and it can be associated with the callosal dysgenesis in around 50% of the cases. There are two types, which is bulky tubulonodular variety, which is also with forebrain and rostral callosal abnormalities. Another one is ribbon-like curvilinear lipoma, which is a C-shaped lesion abutting normal corpus callosum. Then you can see that there is a fat density area in the region of corpus callosum seen on CT and as well as serial MRIs. This is a case of corpus callosum lipoma. This is again another ribbon-shaped C-shaped corpus callosal lipoma seen here. On imaging, again, plain X-ray can show a low density midline mass with varying amount of curvilinear calcifications. On CT, again, this is associated with callosal dysgenesis with fat density mass showing again variable calcification. Here you can see that on the skull radiographs, you can see low density midline lesion, and on CT you can see that there is some curvilinear calcification along the fat density mass. This is a corpus callosal lipoma. Next, coming to the sulcation and cellular migration abnormalities. This includes lysencephaly, that is smooth brain, due to absence of poor sulcation. Next, intrauterine infections can result in similar appearance. Again, based on types, it can be complete agaria or incomplete, that is agaria pachygaria complex. Again, based on lysencephaly, again there are two types, type 1, type 2, which is also with cobblestone lysencephaly or without. The type 2 again has some neuronal hypoplasia. This is that you can see that there is the smooth brain without absent gyri and sulci formation. So giving rise to appearance of a H-shaped ventricle here. This is a lysencephaly. Then another migration anomaly includes schizencephaly. This here there is a CSF-lined cleft which extends from the ependymal surface through the white matter into the cortical surface of the pair. So this is a CSF-lined cleft. It can be widely separated cleft, which is known as open lip, that is type 2, or the walls can be in apposition, that is closed lip. Again, other types of schizencephaly you can say include unilateral schizencephaly or bilateral schizencephaly, symmetric schizencephaly or asymmetric schizencephaly. Here is an example of schizencephaly wherein you can see that there is a CSF-lined cleft extending from the ependymal surface to the cortical surface. One important thing to identify is the cleft is lined by the gray matter. This needs to be identified because unlike a porencephalic cyst, where there is brain dissection and replaced with a porencephalic cyst, in porencephalic cyst it is lined by a glial tissue, whereas here it is lined by a well-formed gray matter. So it's a gray matter lined CSF cleft, that is schizencephaly. Here you can see that the cleft is widely open, that is open lip schizencephaly. On CT, sometimes closed lip schizencephaly can be very difficult to identify unless the proper windowing is used. You can see that there is a small cleft here, which is lined by gray matter. So it's a closed lip schizencephaly, which is extending from the ependymal surface into the cortical surface. The same on the MRI. Here another example of open lip unilateral schizencephaly in the right frontal lobe, again lined by gray matter. These are the examples of bilateral schizencephaly. Again, it's a bilateral closed lip kind of schizencephaly, seen symmetric on either side. And coronal MRI, again, you can see that it's lined by the gray matter. This is a bilateral open lip schizencephaly, widely open and patent cleft, lined by the gray matter. On imaging, again, CT and MRI are the important imaging. Closed lip, if even when the gray matter is not clearly seen, there is slight outposting of the ependymal surface, or full thickness by ependymal seam can be seen. In open lip, there is a large gray matter line CSF cleft. Again, as I told you earlier, the differential possibility includes the porencephalic cyst, second to insult to the normally developed brain, which is replaced by CSF fluid, but it is lined by the gliotic white matter. Next, coming to the other migration abnormality, that is heterotopia. Heterotopia is the collection of normal neurons in the abnormal locations. That is secondary to neuronal migration arrays along the radial fibers. Heterotopias can be again focal or diffuse heterotopias. Based on the location, they can be divided into three types, that is subependymal heterotopias, subcortical heterotopias, or band heterotopias, which gives rise to double cortex kind of appearance. Here you can see that the first type, that is subependymal heterotopias, that is the gray matter lined heterotopias seen along the subependymal region of the lateral ventricles. One differential diagnosis in these subependymal heterotopia includes the nodules in case of tuberous sclerosis. But again, the subependymal nodules in tuberous sclerosis are slightly irregular and mildly enhancing. And they're often calcified on CT scan. The subcortical heterotopias, again, you can see that the gray matter rests along the subcortical white matter. You can see that. Whereas band heterotopias are all along the cortex, which gives rise to double cortex kind of appearance. You can see that there are two lines of cortex here. So this is the case of band heterotopias. Next, coming to the hydranencephaly. Hydranencephaly is there is destruction of the previously formed brain. So usually the fox is present here, but the brain parenchyma is replaced with fluid-filled cavities with very thin cortical mantle or brain mantle, and there is no recognizable ventricles as such, but the basal ganglia are usually intact. This again, when it's very severe, it needs to be differentiated from holoprosencephaly. Here you can see that there is very little brain parenchyma and mantle with replaced. Most of the brain parenchyma is destroyed and replaced by the CSF fluid or the fluid dense cyst. Coming to the anomalies of proliferation, it includes microcephaly and macrocephaly. Anomalies of histogenesis include the phacomatous, that is neurofibromatosis, tuberous sclerosis, and Sturge-Weber syndrome. This I think we'll be dealing with in the next session. Microcephaly is quite uncommon, and secondly, it can be due to destructive disorder, infection, or ischemia. Macrocephaly, again, it can be unilateral or bilateral. Unilateral, it can be seen in as hemimegalencephaly, or bilateral, it can be bilateral megalencephaly. Usually, it is associated with migrational abnormalities. Unilateral megalencephaly, it is a hematomatous overgrowth of the part of all of one full cerebral hemisphere. And the enlarged hemisphere can be observed with heterotopic gray matter or abnormal sulcation anomalies. And the white matter can be hyper or hypoplastic. Along with the hematomatous growth of the part of hemisphere, the ipsilateral ventricle is also enlarged. Here you can see that it's a case of unilateral hemimegalencephaly involving the left side. There is the overgrowth of the left cervical in compared to the right, and also there is associated dilated left lateral ventricle. This is another example of unilateral megalencephaly on the left, and you can also see that there is a dilated ventricle on the left. There are some heterotopias, subappendicular heterotopias on the left. Next, moving on to the posterior fossa malformation and cysts. Again, in posterior fossa malformations and cysts, we have Dandy-Walker complex, which includes Dandy-Walker malformation and Dandy-Walker variant, and other miscellaneous posterior fossa cysts such as megacystoma magna or posterior fossa arachnoid cyst. Miscellaneous cerebellar hypoplasias are also included in these posterior fossa anomalies, which includes Chiari IV malformation, Joubert syndrome, Radiologist, tectocerebellar dystrophia, or Lerner-Dicklotis disease. Dandy-Walker malformation is basically cystic dilatation of the fourth ventricle and an enlarged posterior fossa with varying degree of Vermean hypoplasia. The etiology is basically failure of development of anterior medullary velum with atresia of the fourth ventricle outlet. So there is delayed opening of the foramen of Megendie, and there is insult to the developing cerebellar hemispheres. Again, on the imaging and pathology, there is large posterior fossa with high position of the straight sinus and torcular hierophili. On plain radiograph, lambdoid suture inversion is seen. On angio, there is elevation of the torcular hierophili and transverse sinuses. Ventricles and posterior fossa, fourth ventricle floor is present and it opens dorsally into a large posterior fossa cyst. There is associated generalized obstructive hydrocephalus in around 80%. And paragonal abnormalities, there is Vermean and cerebellar hemispheric hypoplasia of varying extent. It is very, in case of malformation, there is severe Vermean hypoplasia, whereas it is very mild in case of Dandy-Walker variant. The Vermean remnant is everted anterosuperiorly above the cyst, and cerebral hemispheres are winged anterolaterally, and brainstem may be hypoplastic or compressed. Can be associated with heterotopias. Often you see such a large cerebellar cyst with a large posterior fossa, large cyst in the posterior fossa with eversion of the remnant vermis and elevation of the torcular hierophili. This is again the cyst seen antenatally in the posterior fossa. This is a case of Dandy-Walker malformation. Associated CNS anomalies include corpus callosum anomaly in around 20 to 25%. Can be associated with heterotopias, gyral anomalies, Hydranencephaly and Cephalocele. And non-CNS anomalies include polydactyly and cardiac anomalies. Dandy-Walker variant, as I told you, is a mild form of Dandy-Walker complex. There is mild Vermean hypoplasia. Fourth ventricle communicates dorsally with a cyst or a cisternum magna through a slit-like opening, which forms a keyhole kind of deformity. Fourth ventricle is slightly enlarged, and posterior fossa, brainstem, and third and lateral ventricles are usually normal, unlike the Dandy-Walker malformation, which is the most severe form. And you can see that there is mild Vermean hypoplasia with fourth ventricle communication into cisternum magna through a keyhole variant, cleft. This is a case of Dandy-Walker variant. Other miscellaneous posterior fossa cysts include, as I told you, megacystoma magna and posterior fossa arachnoid cyst. Megacystoma magna, cerebral hemispheres, vermis, everything is normal here. There is slightly large posterior fossa with large cisternum magna, and there can be prominent scalloping of the occipital stomach, but this scalloping is much higher in case of arachnoid cyst. But the most diagnostic way to differentiate arachnoid cyst from cisternum magna includes the induction of interthecal contrast, which readily opacifies megacystoma magna as it is communicating with arachnoid cyst, whereas it doesn't opacify the arachnoid cyst. Here is an example of megacystoma magna. Other miscellaneous cerebellar hypoplasia and dysplasias include Chiari IV type and Joubert syndrome. Joubert syndrome is an autosomal recessive disorder with totally disjointed vermis, which is split and segmented and totally disorganized. And the fourth ventricle roof is convex superiorly. There is no hydrocephalus here, but it can be associated with the callosal dysgenesis and congenital retinal dystrophy and developmental delay. In Joubert syndrome, again, the dysgenetic vermis, along with it, there are thinned out cerebellar superior and inferior cerebellar peduncles. On MRI, it gives rise to what is known as typical molar tooth appearance because of degenerative vermis and thin cerebellar peduncles. Here is another example of Joubert syndrome. Other posterior fossa abnormalities with the cerebellum includes rhombencephalous synapse. This is is very rare. The cerebellar vermian agents are hypogenesis with total midline fusion of the cerebellar hemispheres and peduncles, and it is associated with ventriculomegaly and absent septum pellucidum. Here you can see that there is no differentiation into right and left cerebellar hemispheres, which are totally fused in the midline with vermian dysgenesis. Then coming to the Lermite-Duclos disease, this is a dysplastic gangliocytoma of cerebellum. Here there is totally hypertrophied granular cell neurons and axonal hypermyelination. There is gross thickening of the cerebellar folia with or without mass effect. This is associated with Cowden's disease and neurocutaneous syndrome. Here you can see that it is a dysplastic cerebellum which appears hypodense, and on CT also it appears very hypodense. On CT it appears as iso to hypodense region and does not enhance following contrast enhancement due to the dysplastic tissue. There is some mass effect and displacement of the fourth ventricle, and the calcification can be seen occasionally, and hydrocephalus also can be seen. And it appears low signal on T1 MRI and laminated or folial pattern with increased intensity on T2. And the other part of this CNS anomalies, what I left out is the anomalies of histogenesis. That includes the neurocutaneous syndromes and leukomatosis. That is neurofibromatosis type 1, type 2, and tuberous sclerosis, Sturge Weber syndrome. This I think we'll be dealing in the second session.